Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, my name is Ruben Mesa, and I'm the president of Atrium Health Living Cancer, the executive director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center, and excited to join my wonderful colleagues, Dr. Mascarenhas and Bose, today for today's conference briefs highlighting myelofibrosis clinical data from key conferences ASCO, Icahn, and SOHO from 2023. Here's me and my disclosures. This is my friend and colleague, Dr. John Mascarenhas. John, want to say hello?
Hi, everyone. Thanks for having me.
Wonderful. And then Dr. Prithviraj Bose from MD Anderson. Prithvi?
Hi, everyone. Thanks, Ruben. Hi, John.
Wonderful. So your objectives today, we're taking a dive into MF, particularly as it relates to what has been presented at these conferences, with the goal of trying to recognize the burden that patients with MS face on their health, as well as their economic impact that they face. Really, what is the evidence, the risk-informed treatment plans based on prognostic scoring system and emerging risk markers in myelofibrosis? Evaluate the evidence from ongoing clinical trials of novel agents and combinations. Identify relevant clinical trial endpoints and effective treatment strategies to best manage your patients with myelofibrosis. And finally, trying to develop strategies to optimize care for these patients, including patient education, supportive care, and toxicity management. We're going to break this up into three different sections. First, I'll go first with current unmet needs available for the therapy in myelofibrosis. Then Dr. Mascarenhas will take us through the current and emerging JAK inhibitors in myelofibrosis. And finally, Dr. Bose, emerging novel agents in myelofibrosis. So let's kick it off with these current unmet needs of available therapies in myelofibrosis. So this first abstract is one that I presented in the summer and fall conferences relating to the impact of transfusion burden on health-related quality of life in functioning in patients with myelofibrosis. This was a post-hoc analysis where we had the data of the SF36. This is a patient-reported outcome form that helps really measure functionality and impact that patients are having in terms of how well they function. Frequently our assumption that if patients have less anemia, they're going to be able to be more active, they're going to be able to function better, they have better oxygen carrying capacity. And indeed, these data from these two studies, Simplify 1, a upfront study of momelotinib versus ruxolitinib, and Simplify 2, momelotinib versus either the continuation of Rux or best alternative therapy in the second line setting as the data set, comparing mean change from baseline at week 24 in those who were transfusion dependent versus who went then to transfusion independent, so really had that improvement, or those that stayed at transfusion dependent. And what it shows across these 6 parameters of functionality is that there clearly was a favorable impact of becoming transfusion independent upon functionality for patients with myelofibrosis having that level of benefit. So I think this is helpful. I think it helps to show that achieving transfusion independence has a benefit in terms of functionality. We believe it has a benefit in terms of symptoms. Certainly can have an economic benefit as well as a health benefit for patients. Now, as you think about anemia in myelofibrosis, it is a great challenge. It's an adverse prognostic factor, both at baseline and throughout the course of the disease, and can impact the quality of life. Our current treatments have historically been limited. The anemia in myelofibrosis is multifactorial. There's both underproduction of red blood cells from bone marrow failure, but there also can be drug-emergent anemia with medications such as ruxolitinib, that we know ruxolitinib and fedratinib have tended to cause anemia as part of their side effect profile. Inflammation from cytokine production is probably an additional contributor to ineffective hematopoiesis. With myelofibrosis, there's inflammation, increases in hepcidin, leading to functional iron deficiency and defective erythropoiesis. Treatments capable of ameliorating inflammation, reducing hepcidin, may lead to improvement in anemia. Agents capable of targeting ACVR1 and ALK2, which regulate hepcidin, are thought to be potentially beneficial by inhibiting that inflammatory response, improving erythropoiesis. Both pacritinib and momelotinib have been demonstrated to inhibit ACVR1, and both have been able to show a benefit for improving anemia in patients with myelofibrosis. And agents selectively targeting ACVR1 or ALK2 specifically are currently under investigation. This next abstract I liked very much, in that there is very little data regarding the challenges in health equity in patients with MPNs. Indeed, in many areas, both in blood conditions and in cancer, we're really only starting to quantify the degree of the problem, but this was really well done. So this, presented by Dr. Hamami, looked at 5,200 patients diagnosed with primary myelofibrosis, found that 8.3% of the population was Black, which again would be under the national expectation, and again could be a reflection of under recognition of these cases for these individuals. We saw that the Blacks had a significantly younger mean age at diagnosis than non-Blacks, and that Black patients that in this cohort tended to be less likely to be married and female. Also with, signaling, and again, consistent with other studies of challenges in terms of social determinants of health, including median income. We looked at complications for PMF, including leukemic transformation. Leukemic transformation was a leading cause of death, followed by cardiac disease, pulmonary disease, and GI disease. Survival in this kind of non-clinical trial population, but more of a survey, was 69% and 41% at 2 and 5 years. The factors associated with worse survival by Cox regression analysis: age, male sex, Black race, and being unmarried. So I think this is really important complementary information to much that has been published. Many of these aspects really have not been looked at in the large retrospective, typically single institution studies that have occurred in myelofibrosis. Now, one of the ways that we have learned to further assess the symptom burden in patients with MPNs and MF have been patient-reported outcome forms. And Dr. Papadopoulos, who had been with the FDA, had been a collaborator on some of these efforts with us, and this was an abstract which she presented, looking at the updated form of the MF SAF. So this is more specific for myelofibrosis, we're again trying to both harmonize that the different scores are both interchangeable, but also further validation with patient focus groups. So here they had 39 patients complete baseline and retest surveys respectively. There was strong internal consistency, test-retest reliability, non-groups validity, convergent validity, and good discriminant validity. For those of us that are not biostatisticians, what does this mean? Well, it means, one, the patients understand the test. And if they take it more than once, they'll answer consistently. And that it's also helpful for really being able to discriminate difference between one response and another. So if there is a benefit, can you measure it? They also had cognitive interviews and were able to get feedback, and patients generally demonstrated a good understanding of the content and did not suggest any changes to the measures. Indeed, at this point in time, we probably have the greatest amount of validation actually regarding our symptom assessment tools compared to necessarily what is the optimal degree that we shrink the spleen or other aspects. Now, this was a abstract presented by Rami Kamraji from the Moffitt, from the most studies. So this is a longitudinal study conducted both for patients with myelofibrosis and essential thrombocythemia. And here they're looking at disease progression and leukemic transformation in patients with lower risk MF. And again, here they're looking at progressive disease versus not progressive disease. So 232 patients, 59 with progressive disease, and factors associated with patients who progressed. They were older, they were more likely to be Black, fewer were employed, and more were unable to work. I think all indicators of more severe disease. And again, we're just only now wrapping our heads around implications of race or ethnicity in these data sets. Indicators of progression: blood count changes, spleen size, symptoms, and blasts. More low-risk patients had changes in blasts. The symptomatology of patients was not different at baseline as it relates to those who ended up progressing. 57% of the patients had been receiving hydroxyurea versus ruxolitinib. Again, probably not in accordance with the current guidelines. And patients who were receiving ruxolitinib versus hydrea were more likely to have intermediate 1, a palpable spleen, and a longer median duration from the time of diagnosis. So again, important real-world data in terms of how patients are actually being managed at the moment. This abstract here from Dr. Gertz looking at the impact of healthcare resource utilization for those individuals who were transfusion dependent. And again, slicing a group of almost 1,800 patients with MF. This is using Medicare fee-for-service data and dividing patients into transfusion independent, so no transfusions at all, transfusion requiring, or transfusion dependent. Transfusion dependent receiving, again, greater than 6 claims for transfusion on 6 separate days over any 12-week window. So transfusion requiring being somewhere in the middle of that high bar. And my takeaway from this was, one, those, whether you were requiring or dependent, didn't seem to make too big a difference. So if you were needing transfusions, the data looked pretty similar in every way they looked at it, including, one, a greater degree of hospitalizations and greater than 3 visits, 2, greater pharmacy costs, and 3, almost double the overall medical costs that these patients were experiencing. So I think if you're needing transfusions, whether you need a lot or a few, the implications are both problematic for patients.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.